Good afternoon, ladies and gentlemen. My name is Calypso Cholkidu. I'm the Director of Global Health Policy and a Senior Fellow here at the Center for Global Development. And it's a great pleasure to have you with us this afternoon. And hello also to colleagues joining over the internet. I'm also involved in something called the International Decision Support Initiative, which is a network of practitioners, healthcare practitioners and researchers devoted to improving the way resources are spent, money is spent on health around the world, en route to the vision of universal healthcare coverage. And the people we have with us here today are all partners and colleagues who've worked over the years with us in this network, and they've been on the front line helping their healthcare systems make better decisions on spending. And that's incredibly important because right now we all appreciate that there's not nearly enough funding, enough money to provide everybody with everything that could be potentially useful around the world. However, we're all committed to universal healthcare coverage and we're committed to get it there. And I think in that journey, being brave enough to acknowledge the trade-offs, the things that we could be buying but we actually won't because we can't afford it, is really very important, because at least the global health community has in general been rather aspirational in its approach to priority setting for health. And I believe that's now changing fast and ought to change if we're going to get to UHC in an honest way and bring with us populations and all the important stakeholders. And what we're about to discuss today is precisely that. How do countries make these difficult choices? What is the political economy of making these decisions? And what can we learn from one another? And these are decisions that are critical not only to so-called developing countries, but also countries like the United States, where these tough trade-offs are being made day in, day out, where the debate on universal coverage and single payer is extremely topical and a key theme in the current discussion, the political scene. And indeed, we're all faced with very similar challenges. I come from the United Kingdom, where, again, the National Health Service is at the forefront of the forthcoming election. What can we afford? How much money do we spend on health? And what do we do in terms of making and justifying those tough trade-offs? So it's a great pleasure to introduce Amanda Glassman, who's going to moderate this session, and will introduce our distinguished speakers. Amanda is the Executive Vice President and Senior Fellow here at the Center for Global Development, and has been one of the founding members of the International Decision Support Initiative several years ago, and has been working with countries ever since supporting this effort. So over to you, Amanda, and thank you again for coming.
Thank you, Calypso. And please, panelists, join me on stage. So come on up. Where's Dr. Seward? He's left. No. Okay.
He wants a bigger one.
So welcome. As we said, these are really three people who represent partners of the International Decision Support Initiative. They're leaders in the health sector in their countries. And our first, Dr. Suet Wobopalprasert has been a leader in universal health coverage and health systems reform for many years. And I think he's really the perfect one to kick us off to answer the question that animated this session today, which is, how can countries afford universal health coverage? How can we match our aspirations with the monies that are available? So Dr. Suet is an advisor to the Office of the Permanent Secretary of the Ministry of Public Health of Thailand, is a general practitioner and a public policy advocate. He's also an amazing speaker. So thank you for joining us today. We'll start with you. He has some slides, colleagues, and we'll start with you. You have your clicker.
Yes.
Okay.
Okay. Good afternoon. Are you ready? Yes. Good. I just woke up a few minutes ago. When we met with Amanda last time in September, it was at the high-level meeting on universal health coverage. And there was a political declaration approved and accepted. In that declaration, I just try to remind you, this analysis was done last night on the plane. what are the key commitments in the political declaration. I just want to focus on only number 4, which is relevant to what we are talking today. More and better investment. More and better, not just more. And investment, not expense. This is a paradigm shift. Health is not an expense. Health is investment. Not only more money, but better use. And the paragraph of the declaration that related to what I said. For the key target, also paragraph 42, more money for health, 3.9 trillion US dollar more by 2030. I don't want to touch on that. If you do a simple calculation of how big the world GDP is, and this 3.9 trillion account for how many percent, you can do it easily. But paragraph 43 is very important, more public spending on health. The WHO suggests that especially developing countries should put 1% of the GDP public spending on health. It means that public spending on health must increase in the amount equivalent to 1% of the GDP. Okay? And this is a follow-up. And you can see that next year, year after next, and 3 years later, 4 years later in 2023, there will be another high-level meeting to discuss UHC. So people are quite serious on UHC. This is a serious issue. Okay? Now, we are discussing today more money for health, or more health for money, or both. Of course, more money for health is the 3.9 trillion they propose. But I would like to focus today on public spending on health. If you expand health investment, but mainly out of pocket, you put people into catastrophe and medical poverty. What you want to see is expand health investment, but by the public sector. The question is, the WHO suggestion of additional 1% of GDP public spending on health, is it possible? If you look at the public spending in developing countries, usually account for 10 to 20% of the GDP, depend on how much tax, depend on the fiscal policy, whether you want to make loans and do a deficit budget or not. 10 to 20% of the GDP, total public expense, total public investment. Now 1% of 10% is 10%. 1% of 20% is 5%. What does this mean? This means that public investment to health must be increased by 5 to 10%. If my government spend 10% of government's budget on health, it has to increase to 15% or 20%. This is a huge thing. Is it possible? Many countries prove that, at least my country proved that it is possible. When I was new medical graduate, the health spending was mere 4% of the total national budget. Nowadays, it's 15 to 17%, depending on how you define health investment. From 4% to 15 to 17% in the last 40 years. This is possible. Now, if health used to be 4%, and you want to expand 5% more to 9% or 10% more to 14%. You have to eat into other sector, no doubt, right? Other sector must receive less proportion of the budget. Their budget may not be reduced because the budget may increase. The bigger cake may increase. Their proportion may be reduced, but their cake may not be reduced. That's what happened in Thailand. Two most important factors that allow us to increase from 4 to 15% of national budget on health. Actually, three important factors. First is the peace, internal peace. Second, economic growth from export-led international trade. In 1985, we used to spend 25%, 1/4 of our national budget on security because we have internal battle between the government and the communist guerrillas in the jungle. 25% on national security. The same year, we spend 25% of our national budget to pay public debt because we make lots of loans, lots of bonds. We have to pay public debt for development. So in 1985, half of the national budget went to security and paying public debt. But after that, our government, like Ethiopia now have a deal, a peace talk, no more fighting with communist guerrilla in the jungle. The national security budget gradually went down. The total budget did not went down, but the proportion gradually went down. From 85 to 95, 10 years. From 25% down to 13%, 1/3. You have 12% fiscal gap, fiscal space, just from this one. Now at the same time, because of the investment in industrialization and export, we have double-digit growth of our economy. The government was able to collect enough tax to pay off the public debt. 25% of national budget to pay public debt in 10 years reduced to 5%. You have 20% fiscal space. From these two items, you have 32% fiscal space to reallocate to other sectors. Where are they? First, infrastructure. That's the most important thing. Second, education. Third, social welfare. Fourth, health. That's how you get more money for health from the public sector. But that's not enough. You need the third factor is political commitment. Political commitment. Good fiscal policy. In early 1980, when we are still very poor, GDP may be about $500 per capita. The government wants extensive rural development in order to win over the heart of the rural villagers, not to go with the communists in the jungle. What they want to do? They want to lay down health infrastructure from the village to the commune or sub-district and district level. These are rural. But no money. Economic crisis, oil shock. National budget has zero nominal growth, not zero real growth. Zero growth of national budget for 5 years. How can we build rural health center, rural hospital in this condition? The government then made a very bold decision. They decided to freeze all capital investment in urban hospital and hospital in Bangkok for 5 years. Zero investment. This is tough decision because doctors in those urban hospitals are those doctors that attend the prime minister, the deputy prime minister, and all ministers. It was a military government. It was during the primary health for all era. So this political commitment is very important. That's how we have every village, we have village health volunteer, 1 million of them. 1 million village health volunteer in every village. We have every commune one health center, like the health and wellness center that Ayushman Bharat is moving, managed by 5 to 8 non-medical doctors, well-trained nurse practitioners. One key issue for the success of universal health coverage is don't depend on medical doctor. They don't go to the rural area, they are expensive, and they increase cost but does not increase health. I am a doctor, I know. I worked 8 years in rural district. You have to depend on non-medical doctor. Train them. They can solve 80-90% of the health problem without the need of a medical doctor. When I was in India last year, Indian colleague asked me, how can you move doctor to the rural area? I said, we don't move them. We just ignore them. But actually, we move them a lot. But we never have any problem of absenteeism. If I'm assigned to a district, rural district, it's impossible for me not to go there. Impossible. Very strong social pressure, not just legal measures or enforcement. So political commitment is important. Now, more money for health and more health for money. I think more health for money is not much discussed. Even in the high level political declaration, we face difficulties in inserting health intervention technology assessment into the declaration. Finally, we got it. And then WHO people, they insert health intervention and technical assessment and health impact assessment into the same paragraph. I asked them, do you understand that the two things are two totally different animals? Why put them together? I have to go to the top level in order to convince the staff that take it out. This is political economy of even the high-level declaration. So we should focus more on how better investment, not just health economic evaluation to choose the cost-effective technology to be included in the benefit package. That's not a difficult one. The difficult one is what I just mentioned, how to reallocate health budget to the most cost-effective health facilities, like the primary health care. When WHO proposed 1% additional 1% GDP on public spending on health, they put it very clearly that on primary health care, not to put on big hospital, urban hospital, but primary health care. So when India started the Modi Care, the so-called Modi Care, I'm so glad. At first, I thought that, they are going to pay only for inpatient. But when I know that they are going to extensively expand so-called health and wellness center, right? You discussed about that. That is most important. And the key issue I want to stress before I stop is that we, economists or whoever who deal with health, should stop the paradigm of purchaser-provider. It makes me, as a health professional, feel that I'm a merchant of illness. I'm not. I'm a professional. I provide professional service based on my ethic. I want to help people. I'm not a merchant. Don't buy anything from me. If you buy anything from me, it reduces my morale. It reduces my integrity and dignity. and I won't perform well. I'll do everything to get your money, which is bad thing. Purchaser-provider split or purchaser-provider concept is a Western concept. Don't use it. Use your heart. So in our Universal Health Coverage Board, we have both provider and fund manager sit on the same board. We don't split. We don't call them purchaser. We call them financial supporter. Okay? And we move to altruism. We need the heart of the professional. I used to work in rural area for 8 years, actually 12 years, but in the district for 8 years. I never have any problem with money. Money is everywhere, particularly in the temple. People go to temple to donate money. Doctor go to temple to get money. We ask the monk to mobilize fund for us, build hospital, buy new equipment, even hire staff. If you work well, if you are committed, community leaders are ready to support you. You don't have to wait for the money from the government. So this one is very important. Most important thing for developing country, don't expect donors' money. Those are bad money. They usually come with string attached. They usually come with conditions and not sustainable. You have to depend on your own money. Manage it well. It's your own money that is sustainable, not donor money. I'm not saying that you should stop receiving donor money, but receive it wisely, like Rwanda did. We have our plan. If you want to help us, go with our plan, not go with your plan. One of the Minister of Health of Africa used to tell me that, Dr. Sweet, I am not a Minister of Health. Oh, you are, Your Excellency, you are the Minister of Health. No, I am a Minister of Health Projects. Because there are so many donors, so many projects. Every day I manage health projects. I don't manage the whole health system. I'm going to stop now.
Excellent. Very provocative. All right, let's turn to you, Dr. Martha Ganza-Lederer, who's the Director of Technical Coordination, the former Director of Pharmaceutical Services at the Ministry of Health in Ghana, and has really been working for many years to set up the ability of the Ghanaian government, the National Health Insurance Fund, to look carefully at the medicines that they are purchasing as part of the Universal Health Coverage Scheme. And on Friday, October 4th, 2019, not long ago, about a month ago, there was a ministerial inauguration meeting of Ghana's first National Health Technology Assessment Steering and Technical Committee. So congratulations to you and Ghana.
Thank you.
It's been really a lifetime of work.
Thank you.
Ghana is one of the few African countries that's working towards developing a formal health technology assessment function as part of the decision to reimburse their coverage. Can you talk a little bit about the journey that led you to this moment?
Okay. Thank you very much, and welcome to this space. Ghana's road towards universal health coverage started some time back with the enactment of an act on NHIS. That is a very broad government project for financial risk protection. Obviously, it's been a rough journey. Rough because our benefits package is very generous, and because it was politically moved, at this stage, it's difficult to say that you are going to take something out of it. Therefore, it is left with us to begin to manage that system in such a way that we can bring some level of efficiency into the operations of the NHI. And so for a long time, Ghana has always been producing what we call the standard treatment guidelines in its accompanying national essential medicines list. And we have agreed that as we do that, there's no need for the health insurance to reinvent the wheel, but they will use the National Essential Medicines List and adapt the benefits package to fit. So therefore, the NHI medicines list becomes a subset of the National Essential Medicines List. So with that done, it is easier for us to have built a system. And so we began that system building. But somewhere in 2012, the NHI Act was amended because it was not helping the system. Few people are paying the premium. Of course, there are, in the society, there will be vulnerable people. You have to cater for them. And so there are exemptions to those who could pay the premium. And of course, it is just the government tax that is fully funding that. So you are right, that the government fund, of course, we have the donor community in that space, but the percentage is very minimal in terms of funding of the NHI. So when the issues are coming up like this, it is important for us, for those of us who are in the medicines arena, to see how we can support the system to ensure that we bring in efficiency. The first time we began to look at, for a long time, we have used clinical evidence as the basis for selection of medicines. And when the NHI was operating or started operating, it became obvious that we may have to begin to look at economic evidence to get value for money for the medicines we are selecting onto the NHI medicines list. And so that led us to begin to look at what the WHO proposed at the time, grading systems. We use that to define some of the medicines that should go on the NHI medicines list in 2010. But in 2017, when we were doing the 2017, the 7th edition of our standard treatment guidelines, we have a brush with the IDSL. In fact, we have been having discussions on moving health technology assessment forward. And we had a brush with the IDSL, and they supported us to do the hypertension model. And the model used the data from the NHI database. And luckily enough for us, we recognize that the hypertension and the diabetes and a few others became the cause drivers, major cause drivers for the NHI. And so it was making the NHI unsustainable because of the reimbursements are huge and the funds are not matching the reimbursements. Therefore, it is obvious we needed to do some efficiency things. And so we came up with a model. And when we came up with the model, it gave us ideas as to there are cost-effective antihypertensives that could go into the medicines list, and that can free space for more people to be treated. And that's exactly what we did. And it fed into the peer review mechanisms, and the decisions from that model fed into the NHI medicines list. And that is what we see in the 2017 Essential Medicines List. And so in effect, the UHC roadmap is saying that there must be ways by which more people must be covered. And it means that we all move together. That means that partnerships must come on board. Of course, like Subi said, it is important for government to support. But when government resources are limited, there must be partnerships as outlined within the Goal 17 of the SDGs, that we must have partnerships and collaborations that inure to countries and to whoever we are in partnership with. And I think that's exactly what we have done with the IDSL. With their support, we were able to get a decision that informed the NHI medicines list, especially for hypertension. We have not measured to see the savings we have done by the fact that we have introduced cheaper and simpler medications onto the model, onto the list. That will have to be done so that we know that by doing the hypertension model and the decision feeding into the selection process, these are the savings we have done. I think we have to do that study, and I'm sure that that will give us the evidence to show that it is possible that HTA, as we know, HITAP, has been doing all this while, is helpful in bringing efficiency into the way we do business.
Yeah, thank you, Martha. And I think what's interesting about that case is to focus on the places we know where we're spending. It's pretty straightforward to see what governments procure in terms of medicines, what kinds of brands they're buying, what kinds of indications they're buying for, and sort of looking at what is the most cost-effective option available can really make a difference to spending and to getting more UHC to more people. Okay, thank you. So now, Dr. Dinesh Arora, this is your second appearance here at the Center for Global Development on the topic of universal health coverage. He's now at the Johns Hopkins Bloomberg School of Public Health, but he's the former deputy CEO from a couple months ago, really, of the National Health Authority of India, and was a key part of setting up this very large health insurance reform. And he, the National Health Authority is as a quasi-economist, I have been using the word payer, but now Dr. Stewart is reminding us we should probably be talking about financial supporter. You're quite right that that is an unappealing concept to talk about, right? So tell us a little bit about your experience in developing and implementing the PMJAY in India. What insights do you have now that you're on the outside for other countries that are developing similar schemes? And how to make the money go as far as possible?
I think India brings to this table three important messages. And the first message is political commitment. What UHC does today with the declaration is a political commitment at the highest level. And that's very, very important. It opens a policy window. Second step is excellence in implementation. And third is plan well. So India started with the world's largest health insurance scheme not long ago, 1st February 2018, and today, after nearly 1.5 years of completion, it has affected about 5 million treatments and has touched with the e-card dominated by Aadhaar for roughly about 100 million people in 1.5 years. And as we said, yes, we planned it deliberately. It was not only a secondary and tertiary hospitalization scheme, it's also dovetailing primary health care as health and wellness centers. Of course, Health and Wellness Center is, as of now, a supply site with all the PHCs and sub-centers being upgraded. And it's my personal opinion that sooner NHS should get into even purchasing primary health care. That's the way, I'm using the word purchasing because we are still used to that purchasing word. Exactly. But I use the word as strategic purchasing, and it actually helps. I said last time also that irrespective of whether government spends or not, people need health care. In India, we have 3.5% of GDP being spent on health. 1.05% governments contribute, 2.5% people contribute. And people, when they buy, they have information asymmetries. It's ineffective, it's costly, it's time-based, and doesn't yield much result. Governments can do a much better job if they're sincere and if they are committed. I think UHC gives that platform, but that's a beginning. We must not, declaration is just a beginning and a huge task forward. For PMJY, money, it became a Modi case. We always thought that political support is there and it is strongly being followed. The government did one step. 1% of income tax cess was levied on health, for health. So that money is coming out. It's about $100 billion every year. 100 billion rupees, for every year. And that's what is being channelized in Ayushman Bharat. And as of now, it's a big chunk of money for us. We have been able to spend this year about 100 billion, but about 60 of billion we have been able to spend. So we feel that, of course, money requirement will go high. Money will follow if we do well. That's a message. It's very appealing. It's very appealing politically also. And what is more appealing is have a good IT-based system, data-driven systems. Show the results on a data, show the results, how things change, how impactful it is, and it becomes sustainable. So for me, it's scale, it's impact, and then comes sustainability. So scale is huge in numbers in anywhere in India. So where you were showing about the commitment of 2023 of 1 billion, 550 million come from India, as we were discussing in the green room, right? And I'm sure by 2030 another 500 million will be also coming. The missing middle India will be also taken care of.
Yeah.
So when the scale up happens, the next is impact, and with impact, sustainability comes. I think that's the idea which we should move forward towards.
Yeah, I think it's so interesting that you say that, because somebody asked me, are the targets of the UN high-level meeting feasible? And I said, of course they're feasible. Only India has to act, and we're done. Actually, it's not very ambitious, don't you think? Maybe we need to revisit those things. So, yeah.
Amanda, you know what happened? For the last 15 years, we were having National Health Mission, which was doing supply side. They have about 900,000 ASHAs being deployed. It's a community worker in every village, or every 1,000 people, in fact. So this scheme comes at an opportune time and changes the paradigm of demand-driven scheme.
Yeah.
And whenever I am talking to somebody, people talk about different models. Some they say beverage model, which is supply side, or Bismarck, which is insurance model, and third they say out-of-pocket expenses. For me, out-of-pocket is a side effect.
Yeah.
It's not a system. If there is a high out-of-pocket expenses, something is wrong. Something is not delivered. So we all believe in that from day one, that government hospitals are free, but then they have not been able to deliver that. So paradigm shift has happened through demand side financing, and this is a good learning for all of us to move forward.
Yeah, and I think, when we think about the countries that have successfully made dramatic progress on universal health coverage, let's not use the word payment, a change in their commissioning arrangements, in the way that they organize the funding and provision of care, precedes those big changes. And I think the other part of it is that it creates this entitlement for families, for individuals to access care. And that's not about public or private sectors. It's more about what, do you want to
It's a demand side, and on the government side, it comes accountability. When you contract out, say if an NHA contracts out a government hospital or a PHC, it monitors whether it delivers service or not, because it's paying for it. And that link of government buying services. So what's happening on a supply side today? Government buys services from PHCs, give it to people, but that's invisible. It's behind the curtains, and the accountability doesn't happen there. But when an authority like National Health Authority, which is a separate kind of a financial system, starts buying primary care or secondary care, it asks for results, it asks for accountability, and then the whole thing changes. But this accountability has to be driven through IT.
Yeah,
I think coming back to the question you asked, I think that Ghana has. I'll use Ghana because that's where I'm coming from. We realize that a lot of issues are going into curative. The NHI, our national health insurance, is seen as call it a cash cow that providers, are making their whatever from it. But with the advent of these high political decisions that has been made in New York, we have come out with a work package in 7 areas, which includes promotive health, curative, preventive, and palliative, rehabilitative. We have brought in emergency care as well as mental health.
Wonderful.
So we have a 7-service package that is addressing the issue about universal health coverage, because obviously when people can prevent health, they are making health for themselves and they are making health for their families. And in Ghana, we are trying to see health in every policy. That is, if we can see health in sanitation and in water, we can see health in environment, we can see health in planning. I believe that all the monies that go there could be a freeing of the space, the financial space, so that more money can come to health in terms of what we do, because health is actually wealth. And that's the way we have to go.
So, Dr. Stewart, let's talk a little bit about the political economy of universal health coverage. You know, as you said, there's some fights that you want to take all the way, right? You want to make sure that rural facilities are set up, that they're able to be staffed in some way. The ability to freeze spending on urban hospitals seems remarkable to me. What about other, there are, however, some other schemes that exist, like for civil servants or the military, that are separate from the overall universal health coverage scheme and that have different packages. How does Thailand think about that? Was that a fight that was not time to fight, you know, first things first, and maybe talk about those other schemes? Can that coexist with the UHC dream?
You raise very important question, issue actually, political economy. Dinesh, correct me if I'm wrong. What I learned about PMYJ, right? PMJY, is that it was discussed and to a certain level agree to do something since 2016. But nothing happened. No budget. 2017, nothing happened. Until near election in 2019.
2018.
This is a good example. The same as Thailand. The universal decision to have 100% population coverage emerged as a political issue for political campaign. We have to make it a political issue. And when it belong to the people, no one can touch on it. Absolutely. People will fight to death. Another issue of, another example of political economy is the move from supply side financial support to demand side financial support. This is a big move. When I work at the rural hospital, I don't have to care about the people because I get the money from my boss at the ministry. And I deliver the service based on more or less humanitarian. And people are like subject, client, and the patron. The relationship is very vertical. In 2001, when we started to implement the universal health coverage, we decided to shift. We don't give financial support to the hospital directly again. We give it to the people. Every people has a banknote on their forehead. At that time, it was 1,202 baht. It's about $40. Everyone has $40 on your head. And the hospital, the supply provider has to go to them, ask them to you register with me. And then, okay, I can get this $40 into my pocket, one by one. And then use it to pay for the salary of myself, of my staff, pay for everything. This become a demand side. Absolutely. It's very painful. It's not easy, I tell you. The provider want to kill the person who designed this, including me. And the budget, where does the budget come from? Previously, because of the supply side budgeting system, the budget are in several departments of the ministry. You have to go through the detail of each section of each department. Which part of your budget related to UHC? Get out, and pull into the middle. Who love you? No one. They all hate you because you take the budget out of their hand and put into central fund.
Absolutely.
This is a very painful movement. Unless you have strong political support, political backup from the top, the Prime Minister, head of state and the minister of health, you cannot survive. Because the people at that time, they know nothing. They don't care. Supply side, demand side, budgeting. It's not my job. My job is to get the service I want.
Absolutely.
And Martha mentioned about the generosity of your benefit package. We face the same thing. We start our UHC since 1975. You know what is the benefit package? The benefit package is everything we have. Everything we have. So you come to us. We provide service on everything we can provide. If it is service that we cannot provide, it's not in the benefit package because it's not exist. There's no clear benefit package. Actually, we call the exclusion method of defining benefit package, which means everything included except. And the exception list is so small. Usually cosmetic things are exempt. Now your question on 3 schemes. Many people are obsessed that you have to have a unified fund. Every scheme has to be together in one fund. Initially, I also think like that. But when I learn from more countries, I see many countries that is very successful with UHC, but they have many funds. In Japan, they have more than 3,000 funds for many, many years. You go to the European country, Denmark, you go to Netherlands, you go to Germany. How many funds they have? Even private insurance fund as well, not public. So the key question is not how many funds, how many schemes. The key question is how can you harmonize all the schemes with same benefit package, essential benefit package, same service delivery, same financial supporting system. That is the direction that we are moving. And it's not easy. Civil servants, they are powerful. They are the one who control the country. Thai government now is provide financial support for civil servant medical benefit scheme 4 to 5 times higher than the other schemes, without evidence of better health outcome. In certain cases, worse. We have to learn the lesson. Luckily, they are just 8% of the population.
Amanda, my thinking is that health is a political decision and choice. And that is what we saw in September during the high-level meeting. Heads of governments made commitment. They made beautiful speeches. It would be good, like thought leaders like Center for Global Development begins to analyze each government and what they said. In 2023, they will be converging in New York again. Can we find out what they have done in their individual countries, how they have moved UHC to the next level? I think that these are things that we begin to put in motion and begin the measurements from the day they made a speech. I have a copy of my president's speech, and I'm sure as a center you have all of them. And so we can start the analysis and begin to hold governments to it, because if we want health to be a political choice, then the heads of governments must be held responsible for the health of their people. And I think that when we do this, we'll be supporting the move towards UHC as thought leaders.
Absolutely.
Martha, you said you have the copy of the speech of your president.
Yes.
I thought you should say that I wrote his speech.
No,
He has it on his hard drive. There's no problem.
No, I don't read. I didn't write.
I think just to carry on with what Dr. Suvi said. Yes, 2016-17 we were planning, but the click came in 2018 when, of course, what he said was also right, but also when we showed that dream of being the world's largest health insurance scheme. So you need to be politically lucrative also when you talk to them with data. And the data was shown that in government hospitals, which are quote unquote free for everyone, the poor people are getting marginalized. The poor 40% have more chronic morbidity, but hospitalization rate of poor 40% is half of rich 40%. What does that mean? That even for a system which is free of cost, they're getting marginalized. And that's why we went for first step of 550 million, which are the poorest of the country, the disadvantaged of the country. And today, as I said rightly, with the demand side financing, they become the VIP. They have $7,500 in their wallet and they purchase they seek healthcare for themselves. I'm deliberately avoiding the term purchase and pay right now.
Commissioning.
So, commissioning. Yeah. And so they are now going out and asking for the services. And now they become VIP. They're the paid patients. Yeah. And we believe that we will have more facilities coming up in rural areas because that was what was lacking was a paying capacity, which has come up now. Which
some people may criticize us that people will abuse the system and the demand will increase, right? People will, just trivial thing come to the hospital. Is that true? Is there any evidence on that? In our case, after 20 years, outpatient visit increased about 2/3. Inpatient visit increased maybe just 15%.
And that too with the population getting aging and more chronic things coming.
Yeah. And you see people, they are not, sit doing nothing at home and try to come to the hospital. They have to work, they have to earn their living. No one wants to go to the clinic or hospital just for fun.
But this also points out that we should design the scheme well. So let's not go for what America went for, a fee for service initially. It should be package based rather than going for fee for service and dovetailed with primary care, which is a difficult task which India has to do now. And regarding the other schemes, I totally agree because we call the term as convergence. So when we went to the Prime Minister and said that in a one hospital, we have one patient who is coming from PMJY, is getting different package, different services. One comes from railways, one comes from the labor, the employment, the state insurance corporations, and they have a different packages, and it's embarrassing. Should we say that the poor should have low quality or we are paying less for their thing? And it clicked. And so now we are going for what you called as harmonization, convergence of packages and rates for railways, for employment state insurance corporation, which is huge, and for PMJY. That's the first step we're doing. Civil servant step is the next step, a tough step, but we always believe, start with some success begets success.
Absolutely, and really health technology assessment and looking at the impact of what they're purchasing is one way into this difficult
Absolutely,
politics.
when we had this priority of choosing what should we choose from day one, should we purchase secondary, tertiary or all the services combined? So when the kitty is small and we want to establish something, what was more visible and what is more, which can immediately impact is your secondary and tertiary hospitalization. Imagine a country of like size of India with 65% out-of-pocket expenses. You go to a rural village and tell him that how do you wash hands is important or first you get your treatment done. I think initially the unmet need has to be taken care of. We have done it for about 1.5 years, should do for another couple of years, but needs to be dovetailed, linked with primary care. Primary care is still supply side, but it's coming up in a big way as health and wellness centers. My personal opinion is NHS should start purchasing now primary care in a few years after running some pilots, and it should be not only public but even private.
Okay, from your mouth to God's ears. Okay, it's 5, right? Time flew because you were, do we have time? Who's my timekeeper? Shall we have a round of questions and comments from the audience? Please raise your hand, introduce yourself, and say where you're from or where you work. Anyone? Thoughts? Okay, right here, and then in the middle.
Thanks very much. My name's Bob Fryatt. I'm at Associates. I'm Project Director for USAID, a health systems project. Fascinating discussion. Thank you very much indeed. I'd like to pick up on the point made about the need for political analysis and the call for CTD to do that. There are some UHC metrics around that are meant to be tracking UHC, and I'm quite interested in the panel's view on that. I mean, we saw one of the MDGs, initially the indices came out, no one took much notice of them, and then as years went by, they became more and more influential. Do you think we got it right now with these UHC indices? Thank you.
Okay, so we'll hold that. What's our next? Middle, yeah.
Hi.
Yeah.
Is this how it works? Okay.
Hi, my name is Emily.
And my mic's now working. I'm from Johns Hopkins SAIS, and I also have a question about the role of essential surgery in your UHC expansion offerings and how you see that fitting into the primary healthcare discourse and just your opinions on that.
Okay, and a third comment or question? Let's go. Right, before you, and then we'll go to you. We'll let Kamir say something as well. Why not?
Okay, I'm Matiko. This is my second day at IDSI, Jai. Yeah, so just a quick one, especially from the Thai experience. How did you address a little bit more upstream? Because some of the challenges that are facing, especially the low middle income countries, are a little bit high up around, let's say, road safety as a contributor to. So looking at health policies and a lot of other sectors, how did you address issues around we need to, road safety has a lot of impact to some of the outcomes or some of the health investments that you're having, or sanitation and water have all this environmental pollution. The many other problems that are contributing to the bigger picture of food safety. And, looking at all that, how did you address it? And what lessons can we learn, especially from the low middle income countries currently? Thanks.
Okay, so let's go back to our panel. We have 3 questions. One about the variety of universal health coverage metrics. Which ones should we choose? Which should we track? Should we just look at the speeches and hold them accountable for what the president or head of state committed to? What you were the one who raised this accountability issue first, Martha. What's your view?
I think that there are indicators for all the UHC stuff. In fact, for the SDGs, which has even been, at the last count, a few others have been added to it. And I was so happy for antimicrobial resistance. At least we can measure something in there. So I think that as we look at, like I keep saying, UHC must be country-led. Each country knows what is best for them. And I sincerely think that each country will define how they want to move their UHC to what level. Ghana, we think that primary health care is the strategy to move UHC forward. And therefore, our NHIS is being reviewed to incorporate the primary health care strategy into it. And within that primary health care, you have the curative, the promotive, the preventive. So therefore, if somebody will require a certain service, that service could be provided at a level that the person does not need to come to the tertiary care level to get that service done. And so therefore, the plan is how do we move the human capital, that is the health professionals, to be able to meet the needs at the primary level. We had a problem in Ghana where the NHIA have their cards or registration processes. Then the government has also come out with what we call the Ghana card. And the Ghana card is a much superior card because the data set that is used is much more superior. So therefore, we ask health insurance, look, you cannot continue to register people for health insurance card. Why not come together with the Ghana card so that whoever holds a Ghana card can have access to any of the health facilities? So these are some of the harmonization things that must happen. But I think also that technology is providing us a space to be able to disrupt some of the things that are not working so well within our UHC, the road to the UHC. And I think that technology is the next lever we may have to use to bring in some level of efficiencies. Apart from the priority setting tools that are available, I believe that for Ghana, our challenge of the review, I don't know how it's going to happen, but the book of what is in, what is out comes in handy. That you begin to look at that, how can we agree as a country that this is the way we want to go forward? So I believe that each country may have to define what is good. But within that space, I also believe that there should be referees to hold governments to account. And I believe that thought leaders are best placed to do that, because as a staff of government, I cannot hold my government to account. That is to say that you have not done A, B, C, D. But let it be done in such a way that at the next UHC global meeting here in New York, or not DC, in New York, those thought leaders can come out to say that Ghana, you ranked this person, you had that, like what the World Bank does for Human Development Index, so that we know where each one is going based on what we have defined as a country for ourselves, for UAC.
Okay, we'll keep that in account. And okay, how about essential surgery? Well, let's ask all of you, sort of, if you're confronted with a set of interventions that are obviously a priority on many dimensions, what's the process? Let's say probably you have many essential surgery interventions already in your packages, but say there was a piece of that was not. How would that kind of intervention go about understanding whether they could have coverage or not?
I think in India we have done something called unspecified. Even if something is not listed there, it becomes part of the package.
You might want to rethink that. I'm just saying.
No, we are not rethinking it, because for surgical operations, we actually ask for good documentary evidence. One is the photograph before going for surgery, one photograph after going for surgery with a scar wound, as well as at times for cardiac operations, we even ask for a CD, which is getting uploaded on the IT system, so that it is all transparent, it is being done. So I'm sure for surgical operations actually is a much lesser issue than medical things. Somebody getting treated for diarrhea again and again, I can't even document why it happened and it's happening. It can happen. It can be even more of a moral hazard that they're coming again and again. Just wanted to answer his question. You know, I have a feeling that for a UHC, when we are holding accountable, we must also understand that many components of UHC are beyond health ministry.
Yeah, of course.
Like for example, Egypt has put all its 3 agencies they have made. One is for accreditation, one is for health contracting, and one is for insurance as part of finance ministry. So we also need to understand that we need to have good platforms to where these things can come. Ministry of Health is a ministry of disease, and they believe more in operating rather than governing. So and that is public health system only. So I think we need to see that, for example, education, nutrition, women and child departments, road safety, you said, water and sanitation, they have huge impact as social determinants. In fact, going ahead, NHS should think of even when a contribution of 20% from a local self-government for these health services. Right now, the scheme is 60% central and 40% state. I would love to have 10 to 15% contribution from the local self-government, because then they get interested in controlling disease at the primary level. So it's important that we need to have a paradigm shifts even in the institutions we build for them.
Dr. Stewart, on all 3 topics, what do you think?
These are all politics. I think someone should study how the indicator and targets in the SDG were developed. Who are the players behind? If you look at the UHC indicator, there are 2 parts. One is on the service, access to sexual reproductive health, this and that, access to HIV care, and then the other part is on financing, catastrophic health expenditure, medical poverty. Who are the players behind? Why essential surgery is not one of the indicators? These are politics. But health professionals we need to train them well so that they feel responsible. They feel that it's their duty to deliver the best they have. How much we can include in the benefit package depend on how strong, depend on the capacity of the health care system, delivery system of each country. 40 years ago when I started my career, I'm only one doctor of a 10-bed hospital with 8 staff, none of them professional. We are responsible for 200,000 people. We do essential surgery, we do cesarean section, herniorrhaphy, appendectomy. We remove stone from ureter, from pelvis, from bladder, even cholecystectomy. One doctor, 8 staff. Nowadays, the same hospital become 90 bed. They do surgery much less than when I was there. Because now the communication is very good. The big surgery, major surgery, they can go to the bigger hospital easily with specialized doctor. But in my generation, I have to do everything. Because when I say, hey, I cannot do it, you have to go to the urban, the provincial hospital. The patient will kneel down on, not the patient, the relative will kneel down on your knee, on you, and said, doctor, if you send us out of this hospital, we'll go back home to die. This is the last place we can afford to come. So the situation changed over time and over place. Different country has different situation. Of course, we need essential surgery for emergency thing, for elective thing. And for me, I go with the indicator in the SDG. The World Health Organization under Tedros now come with the impact framework and try to measure effective coverage. This is a very good move. Very good move. Not just coverage, but effective coverage. Not just have access to antihypertensive drug, but real control of blood pressure. It's a real good move. Mm-hmm. But it means it creates something new, which most countries does not have the capacity to assess it. We have the SDG indicator. Go with that first. Effective coverage, good. Start small and go big. That is the thing that we are negotiating with the Tedros administration. If you move like that, sorry, member states cannot go with you. And we won't go with you. We won't report to you. And every 2 years, Martha, the WHO, actually we task the WHO and World Bank. But the WHO, if they say that they are working together very well, they are damn lie. Don't believe them. UN agency never work together very well. They fight all the time. They compete all the time.
They have to now.
And the WHO try to kick World Bank out. But World Bank try to squeeze in for this monitoring of this UHC indicator. 2017 once, and then 2019 the second one. We expect 2021 will be the third one. But how this monitoring affect the situation in the country? Does the score make the government feel that they have to do better? I don't know. We need the evidence to support that. I'm not against monitoring. I'm not against accountability. But we need to be able to prove that this thing affects the change in the country. or how this global accountability of global monitoring can affect the change in the country. The second question may be more important because in certain countries it does help, but in many countries it doesn't have any effect at all. Why? And how can you create a situation where this global accountability framework can affect the change in the country? In our experience, the key is whether you have champion in the country on that issue. Road traffic accident is a failure in Thailand, a total failure. It's improving all the time, but still high. And 80% of the accident and death are from motorcycle accident. Drink and drive motorcycle and unsafe motorcycle, even unlicensed, drive without license, without wearing helmet. We have a helmet law since 1995, but the helmet use is just 50%. Even in my own Ministry of Health, we still have cases of people who don't wear helmet and drop down and have head injury and die. Even in the Ministry of Health campus, it's a complex issue which we must prioritize. We can say that it is multi-sectoral. Once it is multi-sectoral, it means that no one responsible. And one of my ministers put it out very clearly that road traffic accident for health sector, we are like waiting at the bottom of the cliff, at the bottom, with ambulance, waiting for someone being kicked down the cliff, drop down to us, and we are ready to help them. But we have to act up there. How can we control motorcycle accident, helmet, drink and drive? It's not in the health sector. Not more than 20% of health problem can be solved by healthcare system. 80% are outside of the healthcare system. That's why in Thailand, we have an act, a legal framework, an act came out in 2009. We call National Health Act. National Health Act. Establish a National Health Commission chaired by the Prime Minister with 39 members, 1/3 from political side, different ministry, 1/3 from academia and professional, health professional. These are the brain. Those are the power, the muscle. And 1/3 from the people, from NGO, from civil society organization. They sit together. And we have a National Health Assembly, like World Health Assembly, every year, with resolution, which mandate, which sent to the cabinet for approval. Once the cabinet approve, it mandate government sector to work on it. But we learn from the World Health Assembly not to follow their mistake. One thing that we agree from the start in the National Health Assembly is that we don't allow lawyers to get involved in the process.
No lawyers.
We interpret our own guideline or whatever we want to interpret right on the spot. If you go to the World Health Assembly, you see legal counsel. They interpret everything, even words. Endorse, welcome, whatever. Even words are interpreted by lawyer. We cannot do it that way. It's too tedious. Why the people are waiting? What being discussed at the UN? What being discussed at the Health Assembly in Geneva? How are they going to affect the people on the ground? And we waste a lot of money and time traveling around the world. Stay there for several days. Talk. But when you go home, no one cares. How many people in Thailand knows about World Health Assembly resolution. How many people in my country read the high-level political declaration? If I don't have to come here, I won't analyze that for you.
Good, thanks for coming. I think that's a good moment to wrap up. But I think that we all share so much of what you've said here today. I think you've laid out a pretty clear path of how to move forward. I would also add, HITAP, the Health Intervention Technology Assessment Program in Thailand, they don't just look at specific medicines or specific interventions, they look at whole policies. And their aim is to influence resource allocation, not just of the health insurer, but more broadly of government.
That's why the name HITAP.
Yeah, exactly.
Intervention and technology assessment, not only technology assessment.
Mm-hmm.
Wonderful.
Yeah. So, it could very well be that looking at the issue of enforcement of helmet wearing, for example, that implies expenditure on the police. Or innovations in helmets, who knows? But anyhow, thank you so much to our panelists, and we'll have a reception afterwards so we can talk more together. Thank you.